Now this seagull speculum has got other uses as well. If you look carefully, the seagull speculum has got a convex lens over here, right? This convex lens, it is having a magnification of 2.5 times. So because of that, you will be able to see better with the help of a seagull's speculum. Okay, and what else are the other uses? Seagull speculum can be used for assessing the mobility of tympanic membrane. Okay, mobility of tympanic membrane can be assessed. Then what else can be done? You can do pneumatic otoscopy. Then you can do fistula sign. Fistula sign can be elicited by using a seagull speculum. Then what else can be done? You can look for the sign which we told now, the Gelli's test, right? Gelli's test requires this, and there is another sign in the chapter on glomus tumor. You will learn Brown's sign. Okay, you will be looking for the blanching. Okay, if it is a glomus tumor, and that is the next thing that is done. Brown sign can be assessed. Then it can be used for instilling medication and sucking the mid-layer secretions. Okay, mid-layer secretions. So these are the various uses of seagull speculum. Okay, seagull speculum. Now coming to the various tuning fork tests that we have already done. What are they? First of all, Rennie's test. Rennie normal means the Rennie will be positive, right? Normally it will be positive. In conductive deafness it will be negative, and in sensorineural deafness also it will be positive, that is AC more than BC. Here BC will be more than AC, here it will be AC more than BC. Okay, in Weber's test, normal means it will be central. In same side, if it is getting lateralized, it is conductive deafness. If it is lateralized to opposite side, it is sensorineural deafness. In absolute bone conduction test, what is happening? The absolute bone conduction test will be the same as that of the examiner when it is normal. When there is a conductive deafness, also it will be same as that of the examiner, whereas in sensorineural deafness it will be reduced. In Schwabach test, when this normal, it will be same as that of the examiner, and in case of conductive deafness it will be lengthened, and sensorineural deafness it will be reduced. In Bing test, what is happening? You are actually occluding the ear canal when a sound is given. Okay, air conduction is actually being assessed. So Bing test positive is what is normal, and Bing test is negative in case of a conductive deafness. In sensorineural hearing loss also you will be getting a Bing test as positive. Okay, and in case of Gelli's test, it will be positive in normal, negative in a particular type of conductive deafness, that is in otosclerosis, and again positive in sensorineural hearing loss. Okay, now there are 3 tests which are used for assessing non-organic hearing loss. What are they? They are the Lombard's test, Shimane-Moose test, and the Thiel's test. Okay, these are the various tests for assessing the non-organic hearing loss. It is usually asked for the exam, but for the sake of knowing the name, you can just learn the name. Okay, it may be asked to tell the names of the various non-organic hearing loss. You need not by heart what it is, because it can be very confusing. Okay, and so it's better to just learn the name. Okay, the various tests done are Lombard's test, Shimane-Moose test. In Shimane-Moose test, we will be occluding the ear, and the patient will say that he is actually not hearing anything. Okay, but he will be hearing better if you are keeping it over the mastoid, right? If he says he can't hear anything, if he is having the same hearing loss even now, then that is indicative of malingering. Okay, so like that, there are 3 tests which you have to know, but you need not go into details of these. Okay, now coming to one of the questions that have been asked. Rennie's test is negative if minimum deafness is 15 to 20 decibel, 25 to 30, 35 to 40 and 15 to 50 decibel. What did I tell you? Yes, for 256 Hz it is 15 to 20 decibel, right? So Rennie's test is first negative when the minimum deafness is 15 to 20 decibel. Okay, so this is for 256 Hz. Then 25 to 30 decibel is for 512 Hz, and for 1045 it is 30 to 45 decibel. Okay, so these are the various frequencies at which Rennie's test gets negative, and you also know that Weber's test is the most sensitive, right? And it can be detected even for 5 decibel of hearing loss. Okay, even for 5 decibel of hearing loss, Weber's test can be detected. Okay, now coming to the most commonly done test for hearing loss. What is that? It is none other than the pure tone audiometry. Okay, pure tone audiometry is the most commonly done test for hearing loss, and so today we will be learning about the two subjective tests of audiometry. What are they? Pure tone audiometry and speech audiometry. The impedance audiometry or the tympanometry, which is a part of impedance audiometry, OAE, brainstem evoked response audiometry, all these you will be learning in the next session. Okay, today we will be learning about pure tone audiometry. What is being done in pure tone audiometry? So in pure tone audiogram, what is being done? You are actually giving tones of some specific frequency, that is, for example, at 0.5 Hz, 1000 Hz, 2000 Hz, 4000 Hz. In those Hertz, the tones are being provided via earphone, and the patient is asked to click on the button provided when he is able to hear. Okay, and for that the loudness of the tone provided is getting increased by 10 decibel and decreased by 5 decibel. Okay, and at the smallest sound he is able to hear, that is kept as the point where he is able to hear. Okay, and in that manner a graph is plotted, and that graph is what is known as the pure tone audiogram. Okay, pure tone audiogram. And so what does it mean if the patient is able to hear at 0 decibel? It doesn't mean that he is hearing at 0 decibel. Okay, 0 decibel is a value which is being taken as the average of how most people hear. Okay, sometimes minus 15 also will be plotted in the graph. Okay, it has nothing to do with the absolute number. Okay, the decibel is the intensity of sound. Sometimes you will have to give more intensity of the sounds than normal. Okay, up to 25 decibel if you are able to hear, then it is considered as normal. Okay, if more than 25 decibel, loudness has to be increased so as to hear the particular frequency tone, then it is considered as abnormal. Okay, so you are plotting a graph. Okay, and how is it being done? You are asked to click. The patient is providing some sound through the headset. Okay, initially air condition is assessed and then bone condition is being assessed. Okay, what is the use of doing this? By doing this you will have an exact quantitative measurement of the hearing loss. Okay, now if a patient comes to you with hearing loss, you now know there are a lot of reasons why the particular hearing loss can happen. For example, if it is a tympanic membrane perforation, if you look here, if the patient is having ossicular interruption with intact drum, the hearing loss is 54 decibel, and with perforation it is 38 decibel. Why this difference is occurring? Because if there is ossicular interruption and if both the oval window and round window are not getting the sound because of the tympanic membrane, there will be more hearing loss. Okay, if there is ossicular interruption and there is perforation, through the perforation the sound can go and directly stimulate the round window or oval window. Okay, so that is not happening here, and that is the reason why the loudness is large in case of a patient having ossicular interruption with intact drum. So when a patient is coming to you with perforation, dematic membrane perforation, if you are going to pose for a laryngoplasty, of course you have to do a patch test. Along with that, you can have a rough idea from the Puriton audiogram itself. Okay, if the hearing loss is more than 30 decibel, it can be indicative of, or more than 40 decibel. Okay, it can be indicative of ossicular interruption. Up to 40 decibel can occur with simple perforation of TM itself. Okay, and up to 40 decibel, why it is like that? Because it depends upon where the perforation is. If it is a posterior perforation, there is more chance of hearing loss, because if the round window and oval window are both exposed because of the perforation, then the round window shielding effect is lost. Okay, the round window shielding may be lost. Okay, and because of that, the phase differential is not maintained, and because of that there will be more hearing loss. Complete obstruction of ear canal can cause 30 decibel hearing loss. So when you are pressing with tragus, or if you are putting an ear plug, the most hearing loss that occurs is 30 decibel. Okay, so there is no use of putting a ear plug and going for loud fireworks. Okay, you can get sensorineural hearing loss even after that, because the complete obstruction of ear canal can cause hearing loss of only up to 30 decibel, and for Malleus fixation it is 20 to 25 decibel. Closure of oval window, and this is seen in otosclerosis. Okay, otosclerosis, I would like to modify it as complete closure of oval window. Okay, only if there is complete closure it becomes 60 decibel. The hearing loss in otosclerosis can vary from 20 to 60 decibel. Okay, and that is because the closure of oval window, when there is complete closure only, the 60 decibel hearing loss can occur. Okay, now what are the uses of doing a Puriton audiogram? You can compare, okay, with the help of Puriton audiometry you can have an exact value, and you can know the type of hearing loss, whether it is a conductive hearing loss or a sensorineural hearing loss or a mixed hearing loss. Okay, conductive, you know that it is when the conductive pathway is affected. Sensorineural means the sensorineural pathway is affected. Mixed means both conductive as well as sensorineural hearing loss being present. Okay, so if there is an exact graphical representation, you can compare, and pre-op and post-op comparison can be done to look for if there is any hearing improvement after the surgery. Okay, and what else can be done? You can do a Puriton audiogram like this, so that you can put a hearing aid. Okay, for a hearing aid trial will need a Puriton audiogram. This is how a Puriton audiogram is done. Okay, the various frequencies are being given here. As you can see here, he is asked to click the button. Okay, in this you can see how a 250 hertz is 125 is changed to 250 hertz, and he is asked to click the button. Okay, and like that Puriton audiogram is being done, and hearing aid trial can be done. Okay, so for fitting the hearing aid also you need a Puriton audiogram. Now what else is the need? For medico-legal purpose. Okay, medico-legal purpose, it is important. Why? Because if a patient comes to you with a perforation after being hit by someone, for example, if a policeman hits a person, and because of that there is a perforation occurring, and because of that perforation, if he is having hearing loss and if he becomes handicapped, that can get him compensation if you know the exact hearing loss he is having. Okay, the exact hearing loss can help. So it is important medico-legally to assess the Puriton audiogram in such patients. Okay, so now what are the various uses? One, you can know the type of hearing loss and at various frequencies. Okay, then you can have a quantitative as well as qualitative assessment. Quantitative implies the amount of hearing loss, and qualitative implies whether it is conductive, mixed or sensorineural. And what else do you know? It is for prescription of hearing aids, for serial comparison, for medico-legal aspect, okay, and of course for assessment of speech reception threshold, okay. Why do you need to know the speech reception threshold? It is for speech audiometry, okay. Speech audiometry also you need this pure tone audiometry, okay. So these are the various needs for doing a pure tone audiogram. Now what are the methods for doing a pure tone audiometry? You can do a huge sun, you can see the huge sun here, Westlake method, and the ASHA method, or the American Speech and Hearing Association method, okay. So these are the two methods of assessing hearing. You need not know the details of these techniques, but just know what is basically being done. The intensity is being increased if the patient is unable to hear that particular tone of that frequency, and it is increased by 10 decibel when the patient is unable to hear, and if he is able to hear, it is decreased by 5 decibel, and like that the lowest intensity at which the patient is able to hear for a particular frequency is being marked in a graph, and with that the graph is plotted, okay. And it is more important that you learn about how the graph is plotted and the different types of graphs that are available, okay, rather than going to these techniques, the difference between these techniques that is never asked for the exam, okay. So initially air conduction plot is made, and after that bone conduction plot is made, okay. Now how is this bone conduction pathway occurring? You know that it can directly stimulate the cochlea as seen here, right? So what is the problem with this? If there is direct stimulation of the cochlea when you are using a tuning fork, or when you are giving the sound signal through the audiometer, the sound can travel to the opposite ear and stimulate the opposite cochlea, okay. So the opposite cochlea can also get stimulated, okay. So to prevent the opposite cochlea from participating in hearing, what you do is you do masking, okay. Masking, for masking what you do is you give a sound, a wideband noise is preferred, it is given at an intensity which prevents that ear from participating in the hearing, okay. So when you are giving sound to the right ear, the left ear has to be masked when you are looking for the bone conduction. In air conduction it has to be masked only when the sound provided is more than 40 decibel. Why is it so? Because the interaural attenuation of sound equals 40 decibel. That is, when you are giving sound via air, the sound gets attenuated when it reaches the opposite side, that is equal to 40 decibel, okay. And this is the reason why only when the sound more than 40 decibel is being given, you are actually doing this masking, okay. So what is this thing known as? This is the Berenice noise box, okay. Berenice noise box. So with the help of Berenice noise box, you can mask the opposite ear. Now you have to learn about the various things which are used for graphing, plotting the graph, various symbols which are used for plotting the graph. Now what are they? First of all, you have to know that right ear is always plotted with red color, okay. Right ear with red color and left ear with blue color, okay. So I will just write here AC unmasked, AC masked, BC unmasked, BC masked, okay. So right is always plotted in red color, okay, and left in blue color, and right is round, R for R. Okay, so AC unmasked right is round and AC masked right is triangular in shape. Okay, triangular in shape. Now what about bone conduction, unmasked and bone conduction? Masked. Bone conduction unmasked will have an opening to the right. Okay, bone conduction masked will open to the right, but it will be a square bracket. Okay,